Africa, and various places. So before we go in for today's webinar, I would just like to speak about few lines about 360 Diagnostic and Health Services. 360 is an organization which is primarily into quality trainings related to laboratory as well as other fields of healthcare. We are giving consulting services as well as the network of laboratories operating with our head office from Noida. Uh, we have network all across India. We've given trainings in Dubai, in Canada, and South Africa. And we keep coming and connecting with our friends all around to share our knowledge and connect with eminent faculties all across. So that whatever experiences are there, they can be shared with our colleagues all around. We are coming up, we keep coming rather, I should say, with various newer trainings. And now we are planning to come up with a training on infection control. Uh, Currently, if you see in the COVID scenario, it is become very, very important that infection control, which is as it is a very important field in healthcare, and especially focusing on COVID, we have to be very, very particular about it. So today we have very eminent speakers with us. To start with, I would request I request my friends to please put yourself on mute.
Dr.
Thank
Pinky,
you.
please unmute yourself. Yeah, thank you.
Thank you. So we have Dr. Rajesh Kumar with us, and we have Dr. Ashok Rattan with us. Dr. Hafiz would be joining us soon. To start with, I would request Dr. Rajesh Kumar. Dr. Rajesh is senior molecular specialist in Ministry of Oman, and he is managing COVID lab there. So let's share his experience specifically in COVID, how they are managing their COVID labs, and we also learn from them. So I request Dr. Rajesh, please, you can take over and start with your presentation.
Thank you, Dr. Bhatia, for the introduction and the opportunity. I'll share my screen. Wait a second. So today's topic for me in this webinar is cost of quality. There is a slight change in the sequence of presentations. Our opening presentation was about infection control in COVID scenario with Dr. Hafiz Saeed from RAK Hospital, Dubai, who had to speak on this topic. But as technology is boon, it's bane also. We can connect all across the globe, but then there are limitations with technology, and it's a good example to quote that technology is bane and boon. Anyway, let's begin with my presentation, which was scheduled to be the last presentation today. But during COVID times, what we have learned is that we have to be flexible, open, and with the modular processes. So I'll begin this presentation. I am Rajesh Kumar, working as a senior specialist with the Central Public Health Laboratory, Oman. And my topic is cost of quality, though you may think it is out of sync with today's topic of the webinar, which is infection control and COVID. But I assure you that this is not out of sync, but perfectly with sync. I'll go to my next slide. Now, this particular slide and dashboard, I think I need not to explain anything because everybody, whether from healthcare industry or not, everybody knows this. This might be the most visited dashboard this year, which tells about the number of cases, number of deaths in all the countries. It gives a lot of statistics, and everyone is following these statistics. So I won't go deeper into this. But as of today, we have more than 61. This slide is made one day before, so number have increased. So 61 million cases and more than 1 million deaths across the globe. Indian data is also given in the box in the middle. Many of you might have seen the dashboard WHO, but very few might have seen this dashboard, which is from Amnesty International. And this shows how many healthcare workers have succumbed and contributed with their lives in this COVID fight. This gives you details country-wise. The data is taken from Amnesty International, which tells more than 7,000 healthcare workers have died. And this data is from September. Number might have increased. Indian Medical Association also gave numbers, and 515 healthcare workers, doctors have died in India. And same as there's American data, this is Pan-America, North and South, 2,500 healthcare workers died there, more than 570,000 infections. So you can imagine if number of deaths are 7,000, then how many infections are there in healthcare workers? These slides are just to show you the magnitude. Then this is happening primarily in the beginning. There was a clear-cut lack of PPEs. I hope everybody knows what PPE stands for. And then there was a lack of guidelines, support from the ministries. So there was definitely a gap in the beginning, and still now the gap is still existing, though the authorities, the governments, they all are chipping in, but situation is worse. Then there comes another slide. So during this COVID cacophony, we might have missed that we have a giant killer which kills almost half of the people which COVID have already killed in this year. This killer kills almost half of numbers every year. So COVID comes or goes. This killer, which is infection control related, the antimicrobial resistance, this is going to stay with us, and the number of deaths per year is going to increase. And as UNO estimated, 10 million deaths are going to happen per year by from today after 35 years. So this is an important aspect which WHO mentions it as a top 10 health threats. I am in COVID lab, but I am primarily a bacteriologist, and I understand this threat, and we must all acknowledge, and this threat is growing. Mr. Hafiz was going to speak on antimicrobial resistance and how it's increasing with the COVID because of the use of antibiotics along with the antiviral drugs to contain the virus. But this overuse and sometimes misuse may bring more antimicrobial resistance to us. And we definitely need stricter and stringent infection control measures from now onwards. So my speakers, they'll be speaking later on, Dr. Ashok and Dr. Hafiz. They will very specifically go on alarming MDR resistance in the COVID era. But there are some articles published recently. They all speak about the rising and alarming MDR levels. MDR are those pathogens which are multi-drug resistance. And in hospitals, they are very deadly nowadays. Many of them are gram negative for bacteriologists. They know it very well. They are carbapenemase producing a CRE. This is number one enemy. But then how to prevent these? Because prevention is important. And for that, surveillance programs and stewardship is the need of the hour. Dr. Ashok will speak about it. Another paper from Lancet, it also talks about AMR surveillance, policies, diagnostics, and vaccines. So clearly we have publications coming up which are highlighting the importance of AMR in COVID. So all these publications and our experience in our lab also suggest that prevention and proactive measures is the key. For that, resources and funds in COVID cacophony, we should not forget the importance of the killer, which is no less in magnitude. So what we have to accept and address is at the micro level. Micro level means in economy, we call it individual, like individual firm, individual institute. We have to realize that quality. When I talk about quality, quality means the preventions which we are going to implement or put in place, they should be with quality. If no quality, no prevention measure is going to work. And in my topic, I'll address quality. This is more towards the quality, but then we will understand what is quality and what is the cost of quality in following slides. Now, macro level governments, macro is always talks about national economies, national issues, and macro level governments have no doubt, they have realized that there is a need to recalibrate the spending on healthcare. Healthcare was a neglected area in many countries, especially India's condition is not a secret from us. Moving forward for infection control, this is a slide which looks very crowdy. I am not going to speak on each of the bullet, but it tells you that we need control programs, infrastructure, we need trainings, competency, healthcare safety, and so on. There's a checklist, and this checklist is from CDC. So this checklist, if you have to implement, there is certainly a cost, and cost in this time when economies are stretched, institutes are stretched with funding. We have to ask a question whether it's a rational proposition right now to ask for implementation of programs, to ask for quality, whether it's a rational approach. To answer this, we have to go through some of the legends in the field of quality and business. There's a legend from Japan. According to him, cost is more important, no doubt, but quality is the best way to reduce the costs. The another legend which everyone who is into quality, they know him, is kind of guru in quality. He says quality is free. It's not a gift, but it's free. The unquality things that cost you money. So we will talk more about these things. From here, my presentation about cost of quality begins. Here we'll learn the concepts of cost of quality, the understanding of hidden costs, how to reduce, and what are the lessons learned. In providing good quality, quality is a very broad term. We'll explain what is quality. So is it costly? And if it's costly, what is the cost of quality? And why it is important? COQ means cost of quality. Why it is important? So forget even quality COVID era. Anytime if you ask your higher management or your superiors, and if you want to implement some programs, cost comes at the first. What it is going to cost us? If you are not going to tell them the hidden costs and you are not clear about the cost of quality, you cannot explain them and you are not going to convince them. So it is very important to know what is cost of quality. And this is also important to, it works as a tool to know where the important improvements are needed in your programs, and to monitor whether your programs, whether it's for infection control or for biosafety, whatever program you have, whether they are effective or not. So you need to measure. But we have wrong assumptions in our perception about quality. We think quality is goodness. It's about elegance. It's about something looking good. But no, quality is simply conformance to the requirements. Quality, some people think it's not measurable. It's an intangible aspect, but quality is not intangible. It can be measured. It's a cost of non-conformance. Then quality is a problem of quality department. Many people, many organizations want quality department to be the one who has to answer about it. But quality is a shared function. It shouldn't be the part of your clothing. It should be your cloth. Means it's the culture of the organization. Quality is expensive, but in the contrary, quality is cheaper. It's cheaper to do right thing at the first time rather than repeating and doing the wrong things. Quality problem happens due to workers, but in reality, quality starts with planning. And yeah, so day and night, everybody from sales to marketing to the lab guys to the hospital guys, they talk about quality. There is nobody who doesn't talk about quality. But if we ask anybody to define what is quality, then I am sure many will struggle. So you can check with yourself, ask what is quality. Anyway, we'll tell you the definition of quality. There's a two definition. First definition is a customer focus and the ability of a service provider. Because we are in service sector, the healthcare, the service provider or producer, they have to constantly meet or exceed the customer expectations. If we are not able to meet or exceed customer expectation, we are not providing quality. There was a survey from Harvard Business Review a few years back, and then the perception of management or the CEOs or the managers were like they are providing good quality. But when they asked similar questions from the users, from the customers, it was contrary. According to the customers, quality was declining. So it's the customer who will tell you what is quality, because you have to meet their expectations and which keep rising with the time. As a manager, what you can do. So there's a famous definition from the guru of quality. The quality is the conformance to the requirements. As a lab manager, as a lab in charge, as a director, what you can do is there are guidelines, there are benchmarks for each industry, for each sector. For like healthcare, for laboratory, there's a ISO, and there are agencies which help you with the quality assurance. There is CAP, WHO, NABL in India. So you have to do quality things, do processes which match the conformance defined by these guidelines. So according to WHO for laboratory, there are 12 quality essential quality systems. Starts with organization, and there are so many, I won't go deeper into it, but there are things that you have to implement. Once you implement things, you will reach to this slide where you have to be reliable, you have to put assurance in the customer, you have to show conformance to the tangibles. It could be your facility design, biosafety design, it could be anything depending whether you're pharma, whether you're healthcare, whether hospital. You have to match certain quality parameters, and then you have to show the empathy and responsiveness. This is a very important slide. It's being taught in all the business schools. It's specifically for service sector. So you are checked on these parameters. So whenever you want to see whether you are doing good or bad, check on these parameters. To achieve conformance to the requirements or exceed them, you need to implement programs, and that need cost. But this is not cost of quality. So what is cost of quality? The price which we pay when we don't do quality things, when we do bad quality, that cost is called as cost of quality. So the price of non-conformance or the cost of poor quality, that is cost of quality. This is same slide, I won't go into it. Now the cost of quality, and this is a simple slide which will help you to remember. There are two types of quality, good quality or poor quality. It's the poor quality which is known as which cost you actually. And in good quality, there is a prevention, appraisal, and there's a failures, internal and external. So what we mean by prevention? Prevention is when we plan something and we implement before actual operation. Let's say we want to implement ISO. So we prepare for ISO, we plan policies, we write SOPs, we do so many things. We purchase biosafety cabinets, we purchase PPEs, all these things which are before actual operation is prevention. Then appraisal costs. When we start operation, we need to make sure that things are working as per the um, parameters, as per the benchmark. So we need to capture our processes at various stages. We need to put the quality controls, we need to do auditings, we need internal auditings, we need external auditings, so many things I will talk about later. And then internal failure, when the failure is caught by us in-house, internal failure, when we don't catch, the customers will catch, somebody will catch. It will not go without uncatched. It can go for one time, two times, but it will be catched. So then we have defined prevention costs. This is generic. For laboratory, there's I already spoke about it, that you have various planning. Appraisal costs, this is generic, inspections and testing. Then there are equipments and the operator costs. I am a laboratory person, so in laboratory we have quality indicators, programs, QCs, all this um, part of the appraisal. Internal failures. This slide, I hope this slides will be available to you. I don't want to talk much because time is a constraint here, but then you will have waste, scraps, reworks, failures. In laboratory, you may have re-examinations, invalid runs, invalid expired reagents. Then you have downtimes, which will cause you problems. And external failures, when things go outside, you may have warranty claims issues, legal issues. In laboratories, you may have lawsuits, lost revenues. So this is a gist of everything, that appraisal and prevention costs are, if you see totality, when we compare all the costs and we put it into monetary terms, it's the external and internal failures that cost money to the organization, not the prevention and appraisal. There are a lot of hidden costs. We need to convert these into monetary terms. I won't go deeper into it, but you can see there is lost sale. There are things which you may not see, which are not visible, but they cost you much more. And if you implement the prevention, if you increase the cost in the preventive measures, definitely your overall cost comes down, and this makes quality programs free. This is just an example. Let's say in Corona time, we have biosafety cabinet. If we implement biosafety cabinet, let's say class 2, B2, and then trainings, SOPs, as per WHO or ISO, this is prevention. Appraisal is when we check the airflows, periodic calibrations, particle counts, fume testing. This is all appraisal. But then there is failure. Failure will expose and result in the infections in the operator or the colleagues, or it may go outside also. If you go outside, then you will have legal problems. This is all possible. So when you start implementing quality programs, you start spending on it, your total cost of quality starts coming down. And this is where there's a trade-off. You don't want to keep spending on the cost. You have to see your goals, your market proposition. Maybe you don't want to be a quality leader in the market. So with conformance, you have to see your goals also. And this is where you have to reach your optimal quality. This is a triangle which tells you $1 spent on prevention is equal to $10 in internal failure and $100 in when it goes out. Lessons learned during pandemic, we have a lot of lessons, the supply problems, the supply shortages, and the monopoly of supply, especially in the Middle East. We have all these issues, and they cause quality to go down. We have to make sure that we don't depend on one supplier. We always should have long-term association with suppliers. Supplier verification is very important. Don't depend on one supplier, develop other suppliers also. So we should always give orders to at least 2 suppliers, small order and larger order if possible. So keep them engaged with you for a long time. And then they also work for you when crisis hits. Quality must be extensive, not in COVID time, we have expanded from CPHL, we have more labs, public health and health infrastructure has expanded, but did our quality also same in all the locations? We have to make sure that it is same. Flexible quality processes, we have to make sure that now onwards, we should not wait for the pandemics to hit us or crisis. Our processes should be open. Our instruments should be open and scalable. Takeaway messages that infection control and corona brought a lot of challenges, but then a lot of opportunities. There's definitely a relation between quality and costs. Prevention is the key. Implementation and compliance is a must. If you have to reduce the cost, reduce the waste. Learn lean management in your system. That is the way to reduce cost. And you can use Six Sigma. This is very important. People should learn about it. This also reduces the problems from the root. And then try to verify for supply issues more than one supplier, avoid monopoly, modular and flexible systems, and implementation of quality processes. Last slide, which if you want to go deeper into it and implement in your place, this is a document from CLSI. It will cost you for non-members $180. This is for those who are interested. Last slide from Philip Crosby, and thank you. That's it for today's presentation.
You're muted.
You are muted, Doctor. We are not able to hear you.
Yeah, I said thank you very much, Dr. Rajesh. And I think you have very beautifully merged the cost of quality and how prevention can help us in a way that we don't land up into problems and we control the things in the very beginning, prevent the things rather than getting into the problems and then looking for, corrections and incurring much more costs than what we have to spend on prevention.
Yes, Doctor.
Yeah. So we'll take the questions in the end. Now I request Dr. Ashok Rattan to take over the topic on antibiotic stewardship. Dr. Ashok Rattan is a well-known figure in the field of laboratory medicine. He's a very senior microbiologist. He is currently advisor Pathkind Labs, Knowledge Forum, R&D and Quality. He is a recipient of APJ Abdul Kalam Life Achievement Award for contribution to healthcare industry. He has published over 100 research papers in peer-reviewed international journals. He is a Commonwealth Fellow and also Southeast Asian Region Organization Temporary Advisor. So I request now Dr. Ashok Rattan to please take over antibiotic stewardship, which I think is a very, very important topic when we talk about the infection and when we talk about the COVID. Misuse of antibiotics can lead to much bigger problems, which we all must understand and we must know.
Can
Over
you
to
see my?
Dr. Rattan.
Can you
Yeah.
see my slides?
Yes,
Okay.
we can see. We can see.
There is. It's coming below. Or 1 minute. It's covering the slides. 1 minute.
Yeah, we can see.
Yeah.
They are very clearly visible. Yeah.
All right. Good afternoon. Good evening, everybody. So today, though the focus is on COVID, but you would notice that because of COVID and because nearly everybody is getting doxycycline or azithromycin or something or the other, the resistance is increasing and we need to pay attention to antibiotic stewardship. you would all agree that the discovery and development of antimicrobials was one of the best invention that could have taken place in the last century. It's as a consequence of the umbrella of protection that antibiotics provide, that heroic surgery like organ transplant, etc., can be performed. In the past, before the antibiotics were made available, trivial infections would lead to death. As a consequence of availability of effective drugs, the deaths as a following community-acquired pneumonia have decreased from 35% to 10%, from hospital-acquired pneumonia from 60% to 30%, from heart infections from 100% to 25%, from brain infections from 80% to 20%. While using aspirin to prevent clot formation has led to only 3% of change from deaths because of coronary artery disease. Introduction of new antibiotics had been occurring regularly after the first antibiotic was discovered, a chance discovery. Before that, sulfas were tried, and in the 1950s and 50s, every 2 years, pharmaceuticals will come out with new antibiotics, and that could be classified as the golden era of antibiotic discovery. Then, after a chance discovery of quinolones, which were actually as a found to be as a contaminant while synthesis of chloroquine, they found that there was a peak which was a contaminant, and when it was tested, it had antibacterial activity, and that's how nalidixic acid came about. And the moment they added a fluorine, it became fluoroquinolone, and it had activity against both gram positives and gram negative. But thereafter, there was an avalanche of Me Too drugs, very lazy chemists making a few changes and calling that as Me Too. And then you had first generation, second generation, and third generation. So it took a lot of efforts before the hurdle was overcome, and oxazolidinone, which actually was initially synthesized for anti-hypertensive drug, was the one which was introduced in 2000. Thereafter, some new molecules have been discovered, but normally what has happened is that around the same time, we have had good advice by persons who should know better. And they had been saying that by the year 2000, nearly all experts agree that bacteria and viral diseases would be virtually wiped out. There was another expert who said, time has come to close the book on infectious disease. And you know what has happened next. Fortunately, bacteria do not go to CMEs, they don't listen to experts, so they are busy getting more and more resistant. And normally, every important bacteria is now resistant. At the same time, because of the advice of experts, investment into new antibiotics have decreased. As a consequence, new antibiotics approval has gone down over the years. So we have a basic problem. While resistance in the pathogens is increasing, investment and new antibiotics and novel antibiotics have been decreasing. So the pipeline is running dry. Emergence and spread of multi-drug resistance, we have been talking for the last 20 years. And many people have suggested many ways of handling it. So let me also try my bit. I feel that spread of multi-drug resistance could be handled by combining infection prevention and control and antibiotic stewardship together. And it rests on three pillars. One is optimize the use of existing antimicrobials. Second pillar is that you prevent the transmission of drug resistance bacteria through infection control. And third pillar is that you improve environmental decontamination. What we need to also understand is that the genesis of current crisis of MDR infection is twofold. One is act of God or act of nature, whichever way you would like to have it. It is spread of resistant genes from antibiotic producing bacteria to pathogens, and then acquisition of resistance to available drugs by mutation. So this is every time the bacteria multiplies, bacteria divides, it has a chance, a finite chance of becoming resistant because of mutation. So that is an act of God, and you and I cannot have any influence on it. What we do have influence is act of mankind, not mankind pharma, but mankind, where selection of resistant mutants by use and overuse of antibiotics is one, and then the spread of multi-drug resistance from one patient to another by non-application of infection control policies is the second. This is where we need to focus on rather than crying hoarse about act of God. So it is when a patient is admitted, we must implement infection prevention and control as well as antimicrobial stewardship simultaneously so that the patient has better things to do. And clinical microbiologists play a big role. There are 6 Ds of antibiotic stewardship. First D is diagnosis, to make the right diagnosis rapidly. And that has been happening in COVID also. I do feel that RT-PCR is not the right test for making diagnosis of COVID, leading to its stoppage of spread. If you want to prevent the spread of COVID, then a more rapid test is what is required to be used so that you have the results in 30 minutes time and you can decide whether the person is infected or not infected. And that is one of the reasons why COVID has been spreading widely and there's no sign of any stop of its spread. The second D is that whenever you feel there's pus, it must be discharged. Pus cannot be treated with antibiotics alone. Then drug is required for any infection, but we should have the right drug based on pharmacokinetics and pharmacodynamics, and we'll cover that to a certain extent, and knowledge of cumulative antibiogram. This is the duty of the microbiologist, which many, if not most antibiotics are most microbiologists are neglecting. And then we must have critical alerts. Fourth is the dose. We should have the right dose for the right duration and do help in de-escalation. Now, Levy and Hara gave the 10 commandments of antibiotic use. And some of the commandments are: we should consider PK and PD when selecting drugs. we should follow only evidence-based guidelines, and we should rationally select the antibiotics depending upon microbiology results. One of the responsibilities of microbiologists is to generate and circulate cumulative antibiogram. And this is a requirement from CLSI M39, which says that at least once in a year, the microbiologist must analyze and present cumulative antibiotic susceptibility report. They should include only final verified results and only when more than 30 isolates are present. If it's less than 30, if it's 1 or 2, we should not then be saying 100% sensitive or 100% resistant, but at least 30 isolates of the same species must be present. We should include only diagnostics and not surveillance isolates. We should eliminate duplicates, because otherwise, if a person stays in the hospital for long, one person will be contributing a large number of resistant isolates to the antibiogram. And it should only include routinely tested agents and not agents that we are using for our projects, etc. We should report sensitivities and so on and so forth. Wherever I have been, I make sure that either the surgeons and the physicians whom I serve, they would have access to what antibiotics, what bacteria are causing infection in their location, and what is the sensitivity pattern, whether it is when I was in Medanta or in Fortis or in UAE. And I would urge you to do the same. And the aim of this is that we then help the clinician formulate antibiotic use protocols, where patients in the OPD are different from patients who attend hospital frequently, and they are different from those who are in ICU. And they would have first line, second line, and third line drugs. But the first step for microbiology labs to contribute to antibiotic stewardship program is to promote reliable results. If you are not performing internal quality control or not participating in external quality assurance program, then you are part of the problem and not part of the solution. So quality, as Dr. Rajesh mentioned, is one of paramount importance if you want anybody to trust your reports. And this would be that you get hold of ATCC strains and and monitor regularly what is the results obtained from various antibiotics, and also participate in external quality assurance program and monitor the results that you get. Quality is never an accident. It's always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. Next is to see that your methods are up to date. Microbiology was born when Leeuwenhoek looked at microbes under this microscope. In 2020, many persons have shifted from that ancient microscope to working on DNA. In these 300 odd years, you need to ask yourself now whether your lab does most of these things. If it does, then if Robert Koch was to visit your lab, would he have a sense of déjà vu? The clinical labs do not appear to have changed much from Robert Koch's time. So he will be able to really associate what he used to do and what we are doing. Nevertheless, in some labs, there is Multitop available, there is Vitek available, there is blood cultures being done using Phoenix or Midget, or staining being done, or Gene Expert available. So it depends on where you are. When, when I was in RAK Hospital for some time, there we had introduced a multiplex system where one sample would get you 16 results. You see here, we were detecting coronavirus 229E, coronavirus NL63, coronavirus OC43 from respiratory samples in 2011. And it would then give report on the presence of not only one, but up to 16 viruses. There were also 5 bacteria which are difficult to culture, like Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella pneumophila, Bordetella pertussis, and Bordetella parapertussis. And also, I would feel that now that many labs are able to do RT-PCR, then the syndromic approach to lab diagnosis would be the way forward. Last year, we had introduced a fever sure panel where for tropical fever, six bacteria, 6 pathogens would be tested simultaneously. There are also multiplex available for STIs or for genotyping of HPV. The third that we can contribute is to make our clinical colleagues use antibiotic use panel, use bundle. Bundle actually consists of simple steps which need to be done together. It's like a toothpick. Each step is like a toothpick. If you want to break one toothpick, it's very simple. But if you combine 5 toothpicks together, I can bet you will have difficulty breaking it. So simple steps combined together in the form of a bundle are known to be very effective for infection control. So initiation bundle is, you are saying, okay, you use the antibiotic if you want, but clinical rationale for antibiotic initiation should be documented. Appropriate sample for smear and culture are collected and submitted to the laboratory before you prescribe the antibiotic. Antibiotic selected according to local policy and risk group as you had helped formulate. Antibiotic ordered as per plan, the name, dose, route, frequency, and tentative duration mentioned when you prescribe, and remove of any foreign body or ID for pus as appropriate. So then once the antibiotic is started, you do not change it for 72 hours. Normally, in most of the hospital, what happens is that every day when the doctor takes the round, and if he finds that the person is not responding, they change the antibiotic, sometimes in the morning, sometimes in the evening, sometimes both the times. But normally, once you choose the right antibiotic, then you wait for 72 hours, wait for all the results to come, and on day 3, you do, was an antibiotic plan documented, review patient's conditions and diagnose after lab reports. If positive microbiology results are there, is there chance for de-escalation? Could IV to oral switch be implemented? And this could be monitored, and this would then help the clinician as well as the administration save a lot of grief. To individualize a patient's antibiotic therapy, you need information on not only MIC, which normally is available, but once MIC is available as a measure of antimicrobial activity, what you require is also what is the rate, what would be the PK/PD parameter which would be useful. PK/PD parameter is, the usefulness is to tilt the balance. Whenever any antibiotic is used, four things happen together. One is clinical cure. You want clinical cure. But whenever you use antibiotics, there's inhibition of non-pathogenic bacteria, there's selection of resistant bacteria, and there's toxicity and side effects if the antibiotic recognizes any target on the patient's body. What we want is use PK/PD to tilt it in favor of clinical cure and to push the three side effects to the periphery. When a dose is given, the drug will then go into various organs. This is the time course of levels in the antibiotic. At the same time, there is time course of activity depending upon what levels are reached. So pharmacokinetics is absorption, distribution, metabolism, and elimination of the drug, while pharmacodynamics is what it does, what the drug does to the bug. And the drug bug combination seems to be, in a simplistic manner, be replaced into two. Either it is concentration dependent or there is time dependent. In concentration dependent, so once the drug is given, you have MIC listed. If the drug is given, there would be a Cmax, which is the maximum level reached. Then there'll be time over MIC, and it will be area under the curve. So the parameters that are required is Cmax over MIC or AUC over MIC. These are the two parameters of success for antibiotics which depend upon concentration dependent killing. For antibiotics which depend upon time dependent killing, it is time over MIC which is important. And from various parameters, they have worked out that Cmax over MIC, if it is more than 10, there will be treatment success. If AUC over MIC is more than 100, there will be antibiotic success. Or in those which are time-dependent killing, time over MIC should be more than 40% of dosing. There are variables, of course, into the picture, but that is only to complicate the situation. Nevertheless, most of the antibiotics available can be swiftly divided into either concentration dependent killing, which is aminoglycoside, fluoroquinolones, daptomycin, ketolide, glycopeptides, aminoglycosides, fluconazole. So it is applicable for both antibiotics and antifungals, while time over MIC is classical for beta-lactams and for clindamycin and oxazolidinones. Proof of the pudding is in the eating. And there were times when I would only talk about how PK/PD would help, but not convert it into action. Then it was a chance encounter with Dr. Dharmendra Sharma while he was also teaching in RAK Medical College. Now he's in Saudi Arabia. And he, being good in Excel, made an Excel program, which we decided we will give free of cost to anybody who's interested, in which all the antibiotics were listed, and from FDA website, the levels were entered. So this program begins. This is the homepage of the program, where there is a drop-down button where you choose the antibiotics that you want to choose. Then you enter the MIC value that you have obtained and enter the dose interval that you want to use. For example, let's say we've chosen linezolid 600 milligrams 12 hourly. The value of linezolid, as you know, is effective only against gram-positive bacteria. So suppose Staph aureus has an MIC of 2 and you want to give it 12 hourly. When you press the button, it'll say that Cmax over MIC is not applicable because linezolid is an oxazolidinone where time-dependent killing is important. Time over MIC should be at least 40%. This is 100%. That means here it will be successful. Let's take another example. If you take levoflox 750 milligrams, the MIC value is 0.5 and you normally give once. When you hit the button, then it says Cmax over MIC because levoflox being a fluoroquinolone is a concentration dependent killing. Here it should be more than 10 since it is 18.5. That means it will be successful. If on the other hand, if you choose ciproflox 500 milligrams 12 hourly, then you'll find that Cmax over MIC is 2.4 and AUC over MIC is less than 100. That would mean that this is red flag. This antibiotics will not work. So with this way, you can individualize the antibiotic stewardship and you can make sure that the person gets the right antibiotic and the right duration. All right, that's all. Thank you.
Thank you so much, Dr. Ashok. I think very beautifully you have described whether it's important to decide whether we need antibiotic or not, which antibiotic, and for how long. I think all these steps are very, very important, which our clinicians need to understand, and labs are there to help. I can see Dr. Hafiz Ahmad has joined us, and I can request Dr. Hafiz. We missed you in the first session, so now we request you to take over. Dr. Hafiz Ahmad is assistant professor and clinical microbiologist with Department of Medical Microbiology and Immunology, RAK College of Medical Sciences, and he is in charge of COVID lab, RAK Hospital. Over to Dr. Hafiz. Yes, we can see your slides.
Yes, thank you so much. Can you hear me now?
Yes, we can.
Can you see my slides, or should I put like this as well?
You can make it full screen.
Right. Is it better now?
Yeah, that's better.
Okay, thank you so much. There's a background. There's Maghrib prayer. That is the evening prayer. Thank you so much for letting me join in. And Ashok Rattan has been my mentor. I think I'm happy that he finished before me. And I think mostly he's covered a lot of the aspects. So we at this topic is definitely so important, especially the antibiotic stewardship aspect and the infection control. And as sir mentioned, they go hand in hand together. So we'll just I'll try to touch upon some points which I felt relevant to discuss, and also in between we'll share some data, and that's why I was not able to share the presentation. If you see, we all know about coronavirus. I think you know more than me by now. The virus, people read up so much on Google, and it's an enveloped virus with the positive strand having these ACE2 receptors. But we also know that having an envelope is a good thing for us, that it can be killed by soap, and simple hand hygiene is a very nice measure of killing the virus, because it's a enveloped virus. And thanks to that, if we follow the guidelines by the government of observing social distancing, or compliance of hand hygiene, then we are very much able to stay away from the virus and try to and stay safe. So there's several things I wanted to just touch upon, is that, as sir mentioned, why is the need for antibiotic stewardship so much? Why do we need this issue of drug resistance organisms which been bugging us for a long time, and we are still in the same boat trying to address this issue, and especially because of the overuse of these third generation and restricted antibiotics, especially in hospitals. So the patient comes to us with the a routine organism. I mean, just not even coming for a treatment, but he gets a gift of a nosocomial infection, and that's why I thought this issue to be pertinent. And so if you see this issue during the COVID pandemic, we see that most of the patients there's an increased susceptibility of resistant organisms, especially it's because of or increase in use of restricted antibiotics because of the prolonged duration of hospitalization, especially in patients having comorbidity or requiring a longer hospitalization. Also, many people who are coming to us with this category of increased uh, elderly patients who are already immunocompromised, and those who are not immunocompromised, they are taking steroids for. Sometimes people just take steroids just for the fact that they may get uh, severe infection, and just to avoid it, they take dexamethasone or some prednisone or any drug which make them more immunocompromised, making them more susceptible to these to these MDROs, especially if they are staying in a hospital. So there are some studies, especially we know that in developed countries, the almost in US, the data says that almost 500 people die of antibiotic, MDROs or resistant bugs. But if it's a case of India or developing countries, the rates are definitely much higher, and we may not even be having an data to share right now. So much so is the rates. Also, the issue is complicated by the co-infections which are there present. Uh, in these patients, especially patients on ventilators, patients on just high flow oxygenations, staying for a week or 10 days plus, because it just adds to the comorbidities, especially for these patients. And that's one of the authors what they identified, that COVID-19 leads to a too much longer hospital stay, especially the hospital days, uh, you know, which is like 8.44 days compared to routine maybe lesser 5.8 days. And that's why even a routine illness like an influenza or a routine pneumonia can complicate the issue. So patients with COVID-19 may experience, positive bacterial cultures. They may are more likely to contract these healthcare associated infections, HAIs, because that's one of the the highlights of this pandemic. And also, we also find that the methicillin resistance staph aureus or MRSA or ESBLs or those or CREs, what Dr. Rattan mentioned, the bugs, which are the elephants, the five elephants, we have increasing MDRO especially, and there the choice of antibiotics is still limited because these patients are already immunocompromised. And MRSA is one of the biggest bug. I'll share some data which is a local data from here. So during the pandemic, the total hospitalization in US decreased almost in many other places. People were scared to go to hospitals for the fact that they may acquire, COVID just by chance from a doctor or from the hospital itself. But that did not change that did not reflect in the antibiotic use. Even antibiotics, which are third lines and ceftriaxones and others, they increased actually in 22%, especially azithromycin, because azithro-hydroxy combination was just used as an empirical treatment. So therefore, we had an increase, usage of antibiotics, and especially in the even people who are using it prophylactically without any symptoms. There was, and because there's no, rationale or there's no guideline which is being developed, especially which is circulated across, which antibacterial or which first line, second line, third line antibiotics to be used in which category of patients. So we find that overall, though the number of patients having co-infections was less, but the utility or the the usage of these antibiotics was very much, and therefore nearly 3/4 of all these patients were prescribed antibiotics, although the number of these patients who were having co-infections was minimal, almost 3.5%. So this is one of the data. Also, one of the literatures they mentioned that antibiotics were used in COVID-positive patients for almost 68% compared to 46% of COVID-19 patients. So there was, statistically shown macrolides, vancomycins, which were reserved. Actually, we've been using these in these patients, and there is a emergence of, the data is yet to come. When we analyze pre and post COVID, you will have an idea of how much of antibiotic misuse we have done. This is one of the papers which I just recently came across, an antibiotic prescription during the COVID-19 pandemic, and very nicely they have discussed the issue. A very recent paper where they mentioned that the studied before and after the epidemics, the first quarter especially, the January to April of 2019, before we had the pandemic, and January and April of the 2020. And they basically, this is from Spain, and they found that the increase in antibiotic was exhaustive increase of our antimicrobial consumption compared to the Q1 of the 2019 to the Q1 of 2020. If you see the curve here, the curve is just going just like exponentially, and that is the number of basically as the detection of PCR has increased, the level of antibiotic use has been increased. So this is one of the papers which also there's another paper which is very likely they try to catch the idea that when we were scared of the virus, we had a very good hand hygiene compliance. But in between and in the end of the pandemic, when people had this COVID, the scare of COVID was gone and people were more relaxed, the hand hygiene compliance has decreased. So this is a very nice study which mentions they have tried to do it across the area, across different hospitals, and they find that the hand hygiene compliance was very high in the initial phases of the pandemic, Jan, Feb, March, but gradually they decreased. And in some hospitals, they found that it was an exponential decrease till this time, maybe October, November. It has gone way below what it was originally, actually. So this is so it reflects on our habits of infection control, of hand hygiene compliance, and others which we keep on talking. But at the end, what the data is there to prove that we are still lacking the compliance, or we are still somewhere not getting it right, and that's why the epidemic is still propagating among us, because we have taken it lightly, and we are not following the norms of the government, especially with masking, social distancing, or be it in hospitals with respect to controlling hospital-acquired infections. So if you see, this is the paper they mentioned that almost in the mid time it was very high, but again it has come to 30 to 40%. This is just across some hospitals which they have mentioned. So the issue is complex. I think Dr. Ashok has already mentioned a lot. It's a the MDROs is a burning issue since Alexander Sir Philemon has mentioned this. He anticipated the issue long term back. Now we have most of these bugs which are coming as a resistant bug, and they are harmless infection. They basically govern our treatment and our prescriptions. And so, if you see, we are no different in Middle East than any other country in India or Sri Lanka or others. Because there is UAE is a very mixed pot of infections, and we have almost everyone from almost 200 communities, 200 countries in this area. So there is rising resistance patterns. We see in this is one of the data from the government authorities in UAE, Abu Dhabi, and which was published in sometime early, but it reflects that the trend that we have these superbugs, and the resistance is there, especially MRSA. If I say, MRSA is being is almost on the rising. I think similar to the Indian studies from AIMS and others, almost 40%, MRSA, which is being also present in this area. So, which is, which can be, decreased, but this is one of the problems we all of us are facing. That if you see the comparison from the other parts of the world, we are almost in between, or on the higher side with respect to MRSA. Also, with Dr. Rathan mentioned the use of antibiograms. So therefore, it's very important, and I think I will, as a good student or as a mentor, sir has inculcated us these habits. So we try to give these antibiograms to the hospitals so that too they can choose their empirical therapy rightly. So luckily we have a good antibiogram, which is this year we just had a JCI accreditation, and we shared them with them these antibiograms. They were happy of. So you see these the green dots, which helps you choose your empirical antibiotics. Is a good thing. So and we also have as a country, UAE has its own antibiogram which the government releases every year, and we are very much in tandem or better with them in terms of susceptibility. Similarly for gram positive. So it's a very important job of a microbiologist to keep the laboratory and the hospital updated with its antibiograms and the prevention of avoiding the routine isolates of screening or the isolates which are not representative of the numbers, less than 30 as Mr. mentioned, is very important. And I think still many hospitals still maybe they don't they don't have the people who are able to generate it, or they are uh, they are somehow not abiding to this, and that's why leading to not so good antibiotic stewardship, or because it reflects your antibiotic stewardship policies. And this antibiotic stewardship policy is now going to be a mandatory thing. I'm part of the UAE antibiotic stewardship committee as a co-chair, and we are trying to be very much proactive in this stewardship program, trying to go to hospitals, even private hospitals, and tell them that the importance of stewardship. So this is our data, what we found, also similar to the UAE data, that the MRSA, we have almost 32% prevalence of resistant bugs. Also, ESBLs is around almost the same percentages. E. coli, Klebsiella, the beta lactams, we have resistance of around 30-35% in all these isolates. The whole now the whole idea of avoiding this or getting the situation better is to have surveillance systems against these bugs, or MRSA, vancomycin, and many labs are not even able to detect them, especially if you're doing it as a kitchen labs. Many labs or outsourcing labs, they don't do it, and that's they may not report it as well. So the surveillance of healthcare associated infections is very important, especially CLABSI, catheter associated UTIs, and ventilator associated pneumonias, surgical site infections, the prophylaxis for surgical site infections, also the timeout policies. So these things are very important in a hospital, a good hospital with good antibiotic stewardship. This is it's a very robust mechanism, and these all things have evolved thanks to the our you know uh, the discoveries and observations of our people who've Semmelweis, or be it the infection control policies, which have made a difference in our which can only unless we adhere to these guidelines, and we know it that these interventions were done and they were life saving. We need to we need to adhere to these guidelines. What I feel is, so I also mentioned the same thing of infection control, but I feel leadership is a big role. No one down the ladder would even bother to do anything if the leadership is not committed to any of these programs. So commitment from the CEO, medical director, and your top-notch, hospital health stakeholders is a must for any of these programs to be successful. Otherwise, they don't happen in isolation. And it's a team effort. And this is how I feel, all these acts can be prevented, especially good hand hygiene compromise. I think everyone knows about these measures. So I will not go into either of these details. It's a short time, but we need to have contact precautions, droplet precautions, especially with COVID times. It's a very much, it becomes very important to have these negative pressure rooms or having airborne precautions. Otherwise, you may be, it's very difficult to have to maintain antibiotic stewardship. So I think to already mentioned this decontamination is also touched upon this, decontamination of equipments. So there are different guidelines for decontamination of equipments, and different bacteria have different survival rates of key pathogens, and these needs to be kept in mind, especially for spillages or with respect to any of those bundles, which is very nicely you mentioned the idea of a bundle. So if you have a bundle, or if you have a 4 5 things together, it's very difficult to, if you follow them, you adhere them very with the discipline, then you will have better outcomes. And that's the only way you can do surveillance of your health infection programs, and try to have data, have the knowledge, and try to get good outcomes. So the processes has to be in place to get the best outcomes. If the process is not there, definitely no one can expect a good outcome, be it a CLABSI or WAP or hand hygiene. You need to have infection control nurse, and especially microbiologist, the infectious disease doctor has to be very much, you know, having this proactiveness for maintaining, measuring these outcomes and trying to publish it or circulate it to the hospital. So that you can avoid these healthcare infections. Especially, we know that in 48 hours, and anything which is ahead of 48 hours comes under this category. And any of these factors, especially the patient's susceptibility, environmental factors, any bacteria, virus, can cause. So I'll skip these slides, as already mentioned a lot of these aspects. But just to remember that many exogenous factors cause infections, visitors, or we are actually transmitting everything through our own habit, especially the hands of the healthcare workers. This is a big issue which can be prevented, and especially the bacteria like pseudo, acinetol, or these bacteria, we can control the transmission by using, and of course, also by these procedures. Also, we can, by using the appropriate antibiotics, you can break the chain of infection. So any of these part of the chain, you need to break the chain to get the best outcome. If you're not able to break the chain of either of these, then it will be very difficult to control. And that's why these are the core elements of infection control: to create a safe hygiene environment, good hygiene practice, surgical asepsis, chlorhexidine washes and waste disposal. Again, is a very crucial area to reduce transpiration. Also, needle stick injuries and occupational exposures. A lot of underreporting goes there. People don't even report these issues, but these are the things which you have to give confidence in your team to come up with suggestions. And a good leader, you have to be good leaders to demonstrate. Also, outbreak management can be, you can, unless you follow up the data, you cannot even you cannot identify if it's an outbreak. Or so we already discussed hand hygiene. I don't want to go into deep. We all know these diagrams, but it is up to us how often we are following it. Otherwise, they just stay as posters in your hospitals and wards. And we are some of these. I just will not go much into it. Uh, so appropriate cleaning, also protective equipment, especially with respect to COVID. I know it's a scarcity of these equipments, but we need to make sure that if you're handling COVID patients, or you need to have these, especially the mask or the prevent or the degowning and gowning procedures has to be taught to doctors, because many doctors are getting infected, and not just because of not knowing it, maybe it's because of relaxed attitude of not trying, because we never wore these things so religiously before. So I think it's a cultural change, and we need to get into the culture of, because COVID it's not going to go away so easy. maybe another 2-3 years, it may be there among us. So waste management, again, is a big part of infection control. Infectious waste, hazardous waste, non-medical waste, all has to be segregated. What in UAE we follow is the grading will be a little different. What we do, I think in India we have categories slightly different than. I don't know if my system is closing. So we have this, we have these colored tags: red, highly infectious; yellow, which is infectious, but it is, and then you have these blue and the tags. So all these go. We have a third-party vendor, which is, which is taking care of this hospital supplies, and all goes through through the third-party vendor. Let me just close it. I don't know if it's causing trouble. Am I not able to change the slide? Okay, shops. So we have this orange colored, uh, orange containers for shops. I think I have some trouble with the slides. Hope I'm able to present. Okay, let me come back again. So these are the. I think everyone knows that red group A, which is highly infectious or waste from research laboratories. They all goes for autoclavable bags, and they are colored tag red here. And then the infectious, pathological, and anatomical, all they go into the yellow and orange, which is the needle stick or a needle, knives, blades. All here we have these containers, special containers, which go for orange, and the rest chemical waste into the blue category. So this is the category we follow here, similar to I think many other countries which follow these guidelines, especially of not doing the resheathing of needles, but straight away you put these needles into these containers. So because if you we all know needle stick injury is mostly the step which is more causing is the resheathing of needles, and this has to be very much avoided. Also, the underreporting issue of needle stick injuries or needs to be brought about, and the culture of congenial environment is to be given to technicians, to the people who are cleaners, and that's the only way you can stop these occupational hazards. So this is one of the students. I'm also, affiliated to the University of RAK, and this is one of the students who presented during one of the conferences here, and the infection control, infection control poster basically. I hope you can see it and just try to appreciate the students who are first year students MBBS. So we are trying to make students also aware of all these infection control habits, because they also go to clinics and wards for for internships and for training. So we try to do an infection control program for the second year students and give them a certification, so that when they go to the clinics, they are already having a good idea of what to do, what not to do in an OT and other places. So we have a committee, which is and a leadership, thanks to our CEO, and they're very dedicated. And we also try to in our hospital, every door, every handle, we try to actually disinfect and take samples from them. So you won't believe, maybe every 2 hours, each door and each handle is cleaned. So it's a very high tertiary care hospital with high rankings, and thanks to that we have very less healthcare infections and a good hand hygiene compliance, about almost 90% and above. So we have a good infection control nurse, and myself as a microbiologist, also our pathologist and infections control team is very active, and we do almost screening for our doctors, nurses, and healthcare. In fact, we are the only hospital to screen our COVID-19, our staff, every month twice for COVID-19. We have almost 500, 600 staff, and including doctors, and every doctor is screened every 15 days for coronavirus, which is, and that too free of cost. So these are some of the things which comes through culture. This is how we demonstrate, because this I presented this some time back, and people ask, how do you how do you measure hand hygiene compliance? So we have these dyes, fluorescent dyes, and very easily you can identify which area in your hand is not, you rub your hand with the fluorescent tags, and and put them in the UV, and then it gives you. So otherwise, you don't know actually. You may be doing surgeries for years, but you don't know actually. And if I tell you that you're not good, then it'll be bad. So you do make them do these, the doctors, and they find out how good they have been doing for the last 15 years or 20 years. So that's a good way of communicating to our colleagues. Also, there's a ATP fluorescence molecules, small handheld equipment available, which can give you the luminescence of different areas in OT, in different areas of your hospital wards and beds. You can find out what is the burden of the microbe. So it can be it is not exactly a culture, but it gives you the microbial burden. So based on that, you can identify. That is our just hospital infection control team with our director, Dr. Su, who's the infection control and just to finally just to sum up, Dr. Ashok Rattan, I hope you hears me. We have improved from RV 16 to 21 panel. We do STIs, all PCR of STI 7, 12 panel. We do meningitis panels, and we have a very nice COVID lab which we have set up, which has and you don't need to touch to open the doors. Every 3 minutes, the room air is exchanged. Quite a well set up lab, very well thought. So I hope Dr. Ashok is proud that I am able to make him proud. And I think he knows this junior. He's also with us, and this is our hospital, RAK Hospital and University team. Thank you so much for giving me the chance, everyone, and I hope I'm able to get my point across.
Thank you so much, Dr. Hafiz, for a detailed experience you have shown and the kind of labs you are working over there. I think these are the scenarios which we all need to follow, because as we all know, and to summarize the whole thing, it is very important that implementation of quality and control of infection is the key for prevention, because in COVID scenario, there is nothing better than prevention. So we all are working on the prevention, and along with that, how we can control the nosocomial infection and how we can have the right use of antibiotics for additional microbial infections is again a very, very important aspect, where antibiotic stewardship and antibiograms are a big help to make use of antibiotics in a current scenario. With this, we end today's session, and I don't see any questions in the chat, but I would like to give the chance if anybody is interested to ask any question, though I can see a lot of praise for all the speakers and all the faculty. People have really liked the presentations and appreciated that. Any questions, anybody? You can unmute yourself and ask the questions. Right. So this shows that everything was self-explanatory, and we could explain what we wanted to say. Thank you so much, Dr. Hafiz, Dr. Ashok Rattan, and Dr. Rajesh for making today's webinar a success. Thanks a lot. And thank you so much, audience, who've been with us for past 1.5 hours. Thanks a lot.
Thank you, Dr. Bhatia, for being awesome moderator, and to everyone who was listening. Though we are half an hour more than what was scheduled, but people stayed with us. So thank you.
Yes, I think I took it last. I think I took more time than it was allotted, but somehow it's advantage and disadvantage both to be the last person.
No, I think your presentation was worth listening, so I didn't stop you in between. Yeah. Thank you so much. Thanks.
All right. Thank you.
Thank you, everyone.
Okay.
All right, thank you.
Bye-bye. Bye. Thanks.